I'm really delighted to introduce Dirk Husmeier from Glasgow, from the SofTMech Statistical Emulation and Translation Hub. And yeah, I look forward to your presentation, Dirk. Thank you.
Yeah, thank you very much for the invitation. So we have our own launch event actually later this month on the 21st of May. And for that reason, rather than give you an overview of our hub, which you can learn more about at our own launch event, I want to focus on two particular challenges. So sort of give some examples of how we are tackling them, and also being hopefully more specific about two of our main challenges we are facing to see well how we can use that to facilitate collaborations between the different hubs. So our motivation is really sort of focusing on cardiovascular disease modeling. So that is already the natural contact point with your hub in Cambridge. And I think I don't need to motivate that any further. So before the pandemic, more than a quarter of all deaths in the UK were related to cardiovascular diseases. That's on average sort of 460 deaths each day. But unlike the COVID-19 pandemic, that is not restricted to the short period of a pandemic, but happens day after day. And there have been impressive advancements in physiological modeling. So the natural question is, does mathematical physiological modeling have the potential to lead to better diagnostic risk assessment and suggestion of treatment options? And in the first part of my talk, I focus on the left ventricle. That is the heart chamber that pumps oxygen-rich blood into the systemic circuit. And we are focusing on one of medical condition we are particularly interested in is myocardial infarction, is heart attack, to sort of find better treatment options and better risk prediction of myocardial infarction. The centerpiece of most of our projects is a cardiomechanic model. And obviously don't have the time to go into sort of details, but here's a simple cartoon plot. So that is a model that reads in at the form of the left ventricle at an early time point during diastole. It has boundary conditions related to the blood pressure profile, and it depends on various constitutive parameters, material parameters. And then we have a mathematical model that can predict the shape of the left ventricle at a later stage during diastole, at late diastole. There's no closed form solution, but we can numerically solve the equations with finite element methods. And that is very much work that was developed in the previous hub. So like the other hubs, we also a second generation hub. So that is work that was done in the previous hub, mainly by my colleagues Hao Gao, Zhang and Ray Ogden. The constitutive parameters of interest to the clinicians. So they characterize the myocardium, the heart tissue, the stiffness, the contractility of the fibers. And in the previous hub, we carried out a proof of concept study where we looked at the potential for classification based on the cardiovascular or myocardial parameters. And it's sort of very clearly distinguishable between healthy controls and heart infarct patients. So that indicates that there is relevant physiological and clinical information in the constitutive parameters of our underlying cardiomechanic model. Now the new hub focuses on well, translation. So ultimately, we want to get the cardiomechanic models into the clinic. And so the question is, what are the main challenges here? I mean, one of the challenges, obviously, is we need to get the left ventricle. We cannot just open the chest and measure the dimensions of the left ventricle. We need to do that in a non-invasive manner, and state-of-the-art techniques are based on magnetic resonance image scanning. So we look at magnetic resonance images, and the state-of-the-art is a manual extraction of the left ventricle. So that requires manual segmentation, motion correction, and then assembly of different slices to then reconstruct the left ventricle. And obviously, we want to well automate it. We want to use machine learning methods to automate the whole process. We've worked with convolutional neural networks, but here's obviously we have a contact point, and sort of is a good way to look for collaborations with the other centers, particularly with the expertise you have in the Cambridge Center. What I will be focusing on in this presentation, again, are the constitutive parameters. As I said, they are of clinical interest, and we cannot measure them. So at least we cannot measure them in a living patient. We need to estimate them in an non-invasive way. And we can do that by comparing the prediction from the cardiomechanic model with the left ventricle that we extract at a later time point of the pump cycle for magnetic resonance images again. So we take magnetic resonance images now at late diastole, we reconstruct the left ventricle, and then we compare that with the prediction from our model. And we can quantify the mismatch, and that defines an objective function in parameter space. So we can either try to find now the best parameters that give us the best agreement, or in order to quantify the uncertainty properly, we can take a Bayesian approach and aim to sample parameters from the posterior distribution based on that objective function that quantifies the mismatch. Now, there are well-established techniques in machine learning for optimization and for iterative optimization and for sampling. But the main challenge here is that we don't have a closed form solution. Whenever we change the parameters, we have to numerically solve the cardiomechanic equation again. And that is based on finite element discretizations, which are computationally expensive. So we typically are looking for computational complexity of about 10 to 15 minutes on a high performance computer every time we change the parameters. And that means standard approaches are just not viable, because it will just take far too long to get the estimation done. And as already was mentioned in the previous presentation, so the idea is emulation. So we want to build sort of a digital twin of our original mathematical model, a statistical surrogate model, which gives the same input-output behavior, but does that much faster than the original mathematical model. So the idea is that we cover the parameter space with some space-filling design. We run forward simulations from the mathematical model. We can do that all in parallel. And then we use established nonlinear statistical interpolation techniques to fill the gaps and get the overall statistical model that now imitates as a surrogate model the original mathematical model. Now, in the earlier center, so that the first center, we carried out a proof of concept study to evaluate how good a model that emulator is. And that study was led by my PhD students, or former PhD students, Vinny Davis and Umberto Noi. And I won't go into the details, but the upshot was that we could really get a good surrogate model with a similar accuracy in the parameter estimation as the original mathematical model, by bringing the computational complexity down from over a week of running simulations repeatedly from the original model now to less than 15 minutes. But the main limitation was that we assumed that the left ventricle geometry was fixed. So the new research hub focuses on getting the mathematical model into the clinic. And here we have to appreciate that every patient is different. Every patient has a different heart. The geometry of the heart changes from patient to patient. We need to allow for these changes and include the geometry of the left ventricle now in the emulator. Now, the left ventricle is typically represented by a high-dimensional grid that you see here, sort of a mesh of finite element nodes. We typically have in the order of 17,000 nodes. That is mathematically a 17,000 dimensional vector space. And there's no way that we can build an emulator in such a high-dimensional space. So one of the research challenges is to find sort of an adequate dimension reduction to reduce that to something that we can practically handle. The simplest approach is principal component analysis, PCA. And here you see sort of a representation of a reconstruction based on projecting the original 17,000 dimensional mesh into a space spanned by the 5 principal components. The gray shaded areas are the epicardial and endocardial wall that we extract from the magnetic resonance image scans, and the red mesh that is the reconstruction based on 5 principal components. So you see that the agreement is not too bad, but obviously, dimension reduction implies information loss that leads to reconstruction error. Whereas at the other hand, now the space of the emulator increases. So going from 4 constitutive parameters now to a higher dimensional space where we have also to include the principal component representations. And that means it leads to an increased emulation error. Physiologists are typically interested in monitoring the stress as a function of the stretch along different directions during the passive filling process diastole. And here you see a comparison between the simulator and the emulator. So the agreement isn't too bad, but there's room for improvement. And also we find that the uncertainty when we're doing that in a proper Bayesian way that quantifies uncertainty is pretty large. So our research projects are several of them are focused on trying to improve that, how to integrate the high-dimensional left ventricle and make the agreement between the emulator and the simulator more better, improve that, and reduce the uncertainty. And just as one of the examples of how that can be improved is to bring prior knowledge in based on ex vivo data. So we work with in vivo data, but there's a lot of information on ex vivo data available. And a widely used study in the cardiomechanical literature is the following by Klotz and co-authors, who empirically found that there is an empirical relationship between the normalized volume and the pressure across a large population of healthy volunteers and people with different disease status. So we want to use that as a prior. So we fit a Bayesian model, properly allowing for the heteroscedasticity of the noise to the data based on the original plot curve law. And that is a model that can now predict the standardized volume at different reference pressures. By fitting now our cardiomechanic model based on the emulator to the in vivo data, well, the model is also capable, knowing the parameters and the underlying cardiomechanic model, to predict the volume at a reference pressure, the standardized volume at a reference pressure. We get two distributions. And if the distributions are in strong mismatch, then we know that we've got parameters that fit our in vivo data, but are not in agreement with the ex vivo studies. So we penalize any distance, any difference between these distributions, and that naturally then leads to a prior distribution on the parameters. Then we can say that looking now at the distribution of the parameter errors, the posterior distribution of the parameter errors, that is from a uniform prior, but when bring the prior knowledge via the Klotz curve in, we substantially reduce the uncertainty and improve the prediction. That's just one of the examples of how we can sort of improve the emulator, in this case, by bringing more prior knowledge in. So that is work done by my PhD student, Ellen Lazarus, in collaboration with Hao Gao and Xiaoyu. Let me now, for the final few minutes, focus on the right ventricle of the heart. That is the ventricle that pumps oxygen-poor blood into the lungs. And our medical collaborators are interested in a condition called pulmonary hypertension. That is high blood pressure in the lungs, which is a major risk factor for stroke, heart failure, and coronary artery disease. And that might not look like a challenge, because you think, okay, then the blood pressure, it can easily be measured with one of the devices you see here, sort of a sphygmomanometer. But one has to appreciate that the blood pressures in the two circuits related to the left and right ventricle can be very different. And you can't use one of these devices in the lung. You can't wrap a sphygmomanometer around the lungs. State-of-the-art techniques are based on right heart catheterization. So you introduce a catheter to then measure the blood pressure in the right ventricle. But that is an invasive technique. It can lead to internal bleeding, to partial collapse of the lung. And so the question is, can our mathematical model help us to make these invasive measurements obsolete and replace them by measurements that are non-invasive, like measuring the blood flow? So the idea is that we start with a CT scan of the blood vessel structure in the lungs. After image processing and improving the contrast and reconstructing the blood vessel network, we then use a partial differential equation description based on the Navier-Stokes equations to link blood pressure to blood flow. These are coupled partial differential equations that depend on various constitutive parameters, mainly related to the stiffness of the blood vessels, and also the boundary conditions that we get by having the effect of the small blood vessels at the terminal ends, which are too small and can't be resolved with the CT scans. They give a natural boundary condition that leads to parameters that have to be estimated. But once these parameters have been estimated, so once our model has been calibrated, then it allows to predict now the blood pressure from non-invasive measurements of the blood flow. And I have to emphasize that is the main advantage, that the blood flow can be measured with ultrasound or MRI, and that is in a non-invasive way, where the blood pressure at the moment requires invasive measurements. So that work has been done by my former PhD student, Miaela Paun, co-supervised by Nick Hill, and in close collaboration with our collaborators at North Carolina State University, Mitchell Colbank and Mette Olofsson. And Miaela presented that work last year at the STEM competition, STEM for Britain competition, where she won the gold medal in the category mathematics. Now, the hub, as I said, focuses on getting the models into the clinic. So we have now a model that upon calibration can predict the pressure from the blood flow, but we now have to allow for the fact that, well, clinicians will be acting on the predictions, and that leads to a sort of closed loop effect. So you see in this diagram that the cardiophysiology depends, it determines the blood pressure. We have a model that predicts the blood pressure, but the clinicians are not just sitting there and watching it. I mean, as soon as they see that the blood pressure reaches a level that is beyond a critical acceptable threshold, they decide on clinical interventions, typically in the form of the administration of vasodilators, but these vasodilators, well, affect the cardiophysiology. That means they widen the blood vessels, they might affect the blood vessel stiffness. That means the model that we have calibrated is no longer valid. So what we actually have to do in order to get it into the clinic is to allow for the fact that we have a closed loop effect here by clinicians acting upon our predictions and do the inference subject to the medical interventions, systematically taking the closed loop effect into consideration. As I said, so that is our research hub. So we started on the 1st of March, and we have a launch event on the 21st of May from 3 to 5 p.m. It's a shorter event. You can find more about it on the SofTMech website. That is the website of our 3 research centers. And also ICMS, the International Center for Mathematical Sciences, who host this event. And at the bottom of this slide, you find the registration link. So please visit the site if you're interested in getting more of an overview and also learning more about the details of some of the methods that I've just mentioned very briefly in my presentation. And I think that is the end of my presentation. Thank you very much for giving me the opportunity to tell you more about our hub. Thank you.
Thank you very much, Dirk. Are there questions? Okay, so can we let Hardy talk as well? Claire, can we unmute Hardy?
I can read it up. So is the left ventricle emulator supposed to replace the FEM solver, or is it used to improve the underlying constitutive relations? The latter case is true. What is improved? So our emulator predicts the same outputs as we get from the simulator. So that is the volume of the left ventricle at end of diastole, as well as the strains. And then we match that against the parameters. So the main focus is really on estimating the parameters. We want to predict the same parameter output functionality as the simulator in order to then learn the parameters, the constitutive parameters. Once we have the parameters, we can insert them back into the simulator. The simulator is then able to give you additional outputs. The emulator really is sort of a surrogate model that helps the parameter estimation. But once we have the parameters, we can put them back into the simulator. The simulator is not a problem if you only use it once. It is a problem if you put it into the loop that you require to estimate parameters or infer parameters. And that is where the emulator is supposed to help the estimation of the parameters.
Great, thank you. Okay, Hardy is happy. Thank you. Thanks a lot, Dirk. That was a really interesting talk. I think in the interest of time, we can postpone more discussions to later.